This is Edward Daniel. Welcome to Me, Med, and More. Case scenario. As a physician expert in intubation, you were called to the ICU for re-intubation of an obese COVID-19 patient who recently self-extubated. The endotracheal tube was noted to be clogged with mucus plug, and the oral airway of the patient was filled with secretions. The nurse noted the O2 saturation of the patient decreased from 94% to 85%, became cyanotic and gasping for breath. The patient has the following vital signs: BP of 80/40, heart rate of 110, respiratory rate of 25, and temperature of 39 degrees Celsius. While doing the pre-oxygenation, O2 saturation still remained at 90% despite oropharyngeal airway insertion. Patient was difficult to ventilate and no chest rise was noted. Don complete PPE. Remove mask from patient if present. A glass shield may or may not be used depending on institutional protocols. In assessment, remember the mnemonic LEMON. Look externally. A brief and targeted exam of the jaw, mouth, neck, and internal airway may help identify features that predict a difficult airway. Obesity generally makes intubation and ventilation more challenging. Some of these features may also be remembered by the mnemonic bones: beard, obese, no teeth, elderly, or sleep apnea and snoring. Evaluate the 3-3-2 rule. It is easily remembered as 3 fingers in the mouth, 3 fingers under the chin, and 2 fingers at the top of the neck. The ability to accommodate 3 fingers in the mouth indicates an adequate mouth opening. Check the Malampati score. It is a classification scale used to predict the ability of a patient's mouth to accommodate both the laryngoscope and your AT tube. Check for obstructions. Conditions such as epiglottitis, head and neck cancer, neck hematoma, foreign bodies, or thermal injury can compromise laryngoscopy, the passage of the ET tube, the BMV, or all 3. Check neck mobility. Since our patient is obese, we should anticipate for a difficult bag mask ventilation. Instruments used: suction, airway, laryngoscope, endotracheal tube, plaster, stethoscope. Also remember the mnemonic MAIDs: cardiac monitor and pulse oximeter, airway, IV fluids, drugs to be given, and suction. You place the patient in a sniffing position for optimal air passage. Folded towels or other materials may need to be placed under the head, neck, or shoulders so that the neck is flexed on the body and the head is extended on the neck. For our patient, many folded towels or a commercial ramped device may be needed to sufficiently elevate the shoulders and neck. For basic airway, first suction the secretions and vomitus that may obstruct the patient's airway. For obese patients, you may use an oral airway to aid you in suctioning secretions. Next, do a chin lift or jaw thrust maneuver in order to displace the tongue anteriorly. To do the jaw thrust maneuver, place your palm on the patient's temples and your fingers under the mandibular rami. Lift the mandible upward with your finger until the lower incisors are higher than the upper incisors. Next, pre-oxygenate the patient prior to intubation to allow the patient to have reserved oxygen. A bag valve mask is used and held by using a CE grip in order to achieve a tight air seal. However, in the case of an obese patient, pre-oxygenate with 100% oxygen for 5 minutes with continuous positive airway pressure or CPAP with a PEEP of 10 centimeters water or with a non-invasive ventilation. Simultaneously, perform the Celix maneuver by applying pressure on the cricoid cartilage with 10 newtons or approximately 1 kilogram. This is important for our patient, especially that he is obese. Cricoid pressure should not be released until tube placement is confirmed. Give anesthetic drugs. Give succinylcholine as a neuromuscular blocking agent. Calculate the dose according to the total body weight or ideal body weight based on lipid solubility. Giving opioids, propofol, benzodiazepines, and other volatile agents in obese patients are less preferred as they exaggerate obstructive sleep apnea and can worsen respiratory depression. Once the patient has been fasciculated and relaxed, increase cricoid pressure to 30 newtons or approximately 3 kilograms and proceed to intubation. Due to obesity, video laryngoscopy is the method of choice. If not available or due to physician preference, direct laryngoscopy may be used. For advanced airway, first make sure to check the patency of the cuff by inflating the pilot balloon and once confirmed, deflate. The laryngoscope is held in the left hand and inserted along the right side of the mouth, pushing the tongue to the left. Depth perception is difficult, and therefore structures should be identified as a blade advances past the tongue and epiglottis. The tip of the blade is inserted behind the vallecula. Traction is then applied along the long axis of the handle, and the jaw and tongue are pulled forward and up off the rest of the face. The blade should not be levered on the teeth as a fulcrum. This should provide a view of the vocal cords. Advance the tube further by increments of 2 cm until the cuff is about 3 to 4 cm beyond the vocal cord. Handle the tube with a pencil grip. The tube should be about 20 to 22 cm in. Once in position, remove the laryngoscope. Inflate the balloon with 10 cc syringe to secure the tube within the trachea. This is done before removal of the stylet. Suction of pharyngeal debris is only indicated if there is massive aspiration, bleeding, or inability to identify the vocal cords. Check the position of the tube in the trachea by bagging the patient and listening. Confirm the proper placement of the tube using 5-point auscultation of the lungs and epigastrium. There should be equal breath sounds on both lung fields and absent gurgling in the abdomen. As a COVID precaution, clamp the tube before removing the bag. Attach it to an oxygen source. Secure the tube with plaster to avoid accidental repositioning or extubation. I hope to see you in my other videos on me, med, and more.